Hello, everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, welcomes you to this, our 9th NDEWS Presents webinar. The NDEWS PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien. My name is Erin Artigiani, and Barbara Kerr, Marwa Al-Nasir, and I will be your facilitators for this webinar. We are all a part of the NDEWS Coordinating Center team. For those who are interested, you can find detailed information about NDEWS, recordings of prior webinars, along with copies of the slides that were used, invitations to future webinars on our website at www.ndews.org, along with a lot of other information about NDEWS and the various activities that we're engaged in with our fellow researchers across the country. You will also find instructions for how to join our NDEWS network and participate in ongoing discussions with more than 1,500 experts and concerned citizens from across the United States and more than 20 other countries. As many of you know, we developed the NDEWS Presents webinars to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. Over the past year, we have seen the use and availability of opioids, and particularly synthetic opioids like fentanyl and those kinds of substances, increase. And we have worked with many of you in the NDEWS network to look for effective ways to monitor, understand, and respond to this situation in an effective and timely manner. This afternoon, we are very fortunate to be joined by two members of the Washington HIDTA High Intensity Drug Trafficking Area, or HIDTA. They are staff who have worked with staff at other HIDTAs to implement ODMAP and regional and local heroin response strategies. Mr. Jeff Beeson, the Washington-Baltimore HIDTA Deputy Director, will provide a demo of ODMAP and talk to you about what they've been able to do since they launched it. And Ms. Peggy Preston, the Public Health Analyst at the WB HIDTA, will present on the heroin response strategy. This webinar will be approximately 60 to 90 minutes long, and we encourage you to submit questions during and after the presentations. Our speakers this afternoon have agreed to keep an eye on questions, and we'll try to respond to them as they come in or after they finish their presentations. Please post your questions in the Q&A box, and if you're having technical issues or other minor questions like that, you will likely get a quick response from those of us here facilitating the webinar. And we will do the best we can to get to all of your questions today. We may miss a few, and if we do, you will see a transcript of the Q&A along with a full recording of this webinar on our website, which we will work to get posted as soon as we can. It will probably be in about a week or two. So I hope that you will enjoy our presentations today, and I'm going to go ahead now and turn things over to Mr. Beeson and Ms. Preston. So thank you all for joining us, and you guys can take it away.
Great. Thank you, Erin. We should have our desktop up on the screen now. Coming up now, there we are. Great. This is an overview of the Overdose Detection Mapping Application Program. What I wanted to do first was talk a little bit about HIDTA and what HIDTA does and why we are positioned perfectly to provide this as a service to our law enforcement and public health community. And then beyond that, we'll move to Peggy to talk a little bit about our heroin response strategy and how we're coordinating on a regional basis. High intensity drug trafficking areas is a federal program. It was authorized by Congress first in 1988. And we're actually funded through the Office of National Drug Control Policy, which operates out of the White House. I'm sure most of you know. HIDTAs, there are 28 of us across the country, and we were established to support law enforcement programs and public health programs by leveraging federal dollars on the law enforcement side to reduce drug trafficking organizations, and then on the public health side to support prevention and, for our case, treatment programs. So we're the Washington-Baltimore HIDTA, which means we cover Maryland, D.C., parts of West Virginia, and Virginia. And we have partners all across the country stretching down to our south in southern Florida and northern California and Oregon and all of those areas. The unique nature of a HIDTA means that we have access to information, resources, and best practices nationally that give us a good opportunity to solve some of the problems that are facing us locally. So as Aaron said, the heroin crisis, the overdose crisis, the opioid crisis that we're facing now is at epic proportions. When we look at the statistics, both fatal and non-fatal overdoses, they continue to increase and they continue to tick up. The genesis of the ODMAP program came from a meeting that we had with one of our local partners, and we were discussing methodologies to respond to overdose spikes as they occur, and lamenting the fact that there really is no good way to share data, oftentimes within our own jurisdiction, and then more importantly beyond our jurisdiction in a regional way. Some counties, some cities have very robust systems to track and monitor overdoses as they are occurring. Other counties are not resourced nearly as well and really have a truly difficult time of understanding the impact that these are having on their communities as they're occurring, or more importantly, to position themselves to mobilize those resources to address a spike as it's occurring. In almost all cases, no information is being shared readily across jurisdictions, or more importantly, across states. So as I said earlier, our position as a HIDTA, we're perfectly positioned to bridge the gap between, and the question came through, should I be seeing slides? You should be seeing the ODMAP login screen right now. And I'm going to take you sort of through how we show that system as we go. We're positioned to sort of bridge the gap between law enforcement, first responders, and the public health community. And what we've done is we've conceptualized an idea that uses a mobile website application that first responders can take information in live in the field, report it into a large database that can then be viewed by public health, police chiefs, fire chiefs in real time in order to mobilize that resource. So I'm going to walk you through this screen right now. As you can see, ODMAP, it's a mobile website. We've registered this site through the Office of National Drug Control Policy, so it is a secure site, but it is intended to be used in the field. I'm going to show you this screenshot right now. This is the system as it's intended to be used, either on a smartphone. In this case, we're emulating it as an iPhone 6, either on a smartphone, on an iPad, or on a mobile terminal in a patrol car or in a fire or paramedic unit. And the interface itself was designed to be very, very simple. We know our first responders are reporting incidents of overdoses in a variety of ways, typically through pen and paper, typically through a report. If they get back to their office, or back to the station, they're calling it in. It's a variety of different ways, and that's what we've heard nationally from our partners. But this is intended to be done right on the scene. So let's talk about the interface. Right here, all we have are 4 options. You know, as we developed this, again, we wanted to be simple, easy, so that we weren't creating any additional or undue pressure on our officers and first responders as they're using the data. So we have our home screen, which you just saw, our contact information, which basically takes you as a link or phone to our help desk if you have any problems using the system. Register for the system. Now, we've just concluded our trial period. We went live with 2 counties in West Virginia along the eastern panhandle and 1 county in Maryland just south of Baltimore City. We began with the West Virginia counties, and again, these are HIDTA counties, which means they're designated to receive support from us, both in terms of dollars for law enforcement, for treatment, for prevention, and then analytical intelligence support here through our Investigative Support Center. So those counties went live, the 2 in West Virginia on January 18th, and then the 1 in Maryland on January 31st. And the 2 in West Virginia went live through their fire and EMS programs in both counties, and the 1 in Maryland went live through their police force. So the important piece to know is that the way this system is designed is it's designed to be used by the best program or best opportunity in a given county or city that's going to yield the most response in order to mobilize that response. So in the registration field that you see here, all we're asking for is that provider to give us their name, the agency, their phone number, their email address, and then to create a simple password. Now, once they hit register, that takes them into an email, and then they confirm an email just like you would do for Amazon or any of the other online systems that you're typically using now. Now, the way we rolled it out to our fire and EMS partners is we came out and presented the system at a large meeting and had them all send the information out to their providers, and they registered individually. With the police unit, we came out and we spoke and had this rolled out through their roll calls. So we have everybody who using the system in their own way and what works for them. So that's the registration process. The login process is here. It's very easy. You just enter in the email address, and then your password, and then you log in. You can remember me, so it's enabled, so you only have one screen to go to, and that is all. So, two things I'll show you on this screen. Again, as an officer or fire EMS, this is the only screen that I'm really going to see and interact with. It automatically defaults to your current location using the GPS coordinates of the device if you are, in fact, in the field. If you're calling it into a center or entering it in from an office, you have an option to enter in an address or an approximate location. This is defaulting to my current location. I'm going to then make a choice. Either on site, it's a non-fatal overdose, or it's a fatal overdose, and then I've either witnessed or administered naloxone myself multiple times, one time, or not at all for either of those options. So for today, I'm going to let it default to my location, and I'm going to click in as a non-fatal overdose, and naloxone was administered multiple times. I'm going to click that. I'm going to allow it to use location services. If they're not already enabled on the device, I can hit allow now, and then it will go through. As you can see here really quickly, it automatically updates in the system, and I get confirmation that my overdose was entered successfully. I see an image on the map, and then it's done. I can then enter next victim if there's multiple victims, or I can log off. Now, if I want to enter an address, I'm going to go ahead and put an address in the system in here. And I'm going to go with 3569 Baltimore Avenue in College Park, Maryland. So I'm going to put that in there, and again, I'm going to go that this incident was a fatal overdose, and we had no naloxone administered. So I'm going to, again, this is a test bed, not real data. We're going to put it right into our test bed. There it is. And again, I'm just using simple Google Maps, so I can scroll into the image if I want to confirm that my location is correct. I can center my image right here so I can see where that location is, and we've done this at the University of Maryland, so I can confirm that that is correct, the building or wherever the location is. And I can go ahead and click correct that it was entered successfully. And then I get that confirmation, and I can jump out of the screen and go back to my screen, put it in my pocket, or go into my next call. A good question was raised on the screen. How do we prevent duplicate entries? That's a great question. For all of our partners who are currently using the system, they will sign a teaming agreement with us. It's a basic document that says, yes, I am Baltimore City Police, Washington, D.C. Police, Texas State Trooper, and I agree that I will contribute data. And then the map, which I'm going to show you in just a moment, that is a map that has sensitive data, and I'm not going to share that with the general public. These are the policies and parameters that I agree to use the system with. So in signing that teaming agreement, we know within a given county or a given response area who is responding to that case. And we like to verify the priority of who will respond. So if there is a geographic location, we'll give you, for instance, in College Park. If the Prince George's County Police are responding to a specific area, state police are responding to a specific area, fire or EMS are responding to a specific area, when we enter into that agreement with the teaming agreement, we identify where those zones are. That's phase one. Phase two is training. We want to make sure that our responders are discussing how they're using the system on the scene. So we want to make sure that if there are two people on there, fire, EMS, and police, that they're having a conversation about who's reporting the data to the system. Step three is on our end. We have a sort of an intercept in the system. If more than one location is submitted within a specific geographic location, within a specific time period, we will get an alert. We'll take that data off the map. We'll then verify that the data is correct and accurate, and then we'll put it back on the map if it is. This morning in one of our counties that did, or yesterday morning it did happen, we had 4 entries submitted for the same location. And it turned out that there were 4 victims in a single vehicle at a single location. We verified the data and put it back on the screen. And as far as evaluation purposes, I'm going to deflect that question to the end, and we'll kind of talk a little bit about that as we get going. Double entries we answered. There are no phone numbers of any of the victims. That was a question. I'm going to talk about the PII in just a moment. So let me go now to the map and where we're maintaining the location. What I just showed you is where our level 1 user would input data. These are our first responders who are arriving on scene and accessing that information. A level 2 user would have to request access to a system for us. We would grant them a login, and then they would have access to the database. We would make sure that these would only be public health officials, fire, police chiefs, supervisory staff, or any analysts within that unit. If there's a substance abuse program in there, we would share that information with them as well. So this isn't data, or access to the system isn't given to the general public. I'm going to go ahead and pull up our map. What I want to say first of all is you see this map on your screen. This is not real data. This is fake data. This is our sandbox. I will show you a broad overview of our actual data in just a moment, but I want to drill down and show you how this system is being used and how it could be used within a specific area. So the first thing that we'll show you, if you look to your left over here in the legend, we're color coordinated. And if you go back to our map, you'll see that those colors coordinate with that level 1 data entry. So that I know all of my blue dots on this map are non-fatal, no naloxone. My red dots are fatal, no naloxone, purple, and so on. So as I'm looking at a quick specific area, I'll be able to see what is going on and how they're dispersed in that area. This is the total incidents submitted. Now, this is for the U.S. at this point in time, but we will customize this dashboard for any localities as they're entering in data. So if we were, I just did a demonstration for Knoxville, Tennessee before getting on here. So if Knoxville wanted to have this customized, we would customize this dashboard for Knoxville for the total incidents submitted within the given year. If they only wanted to have the 3 surrounding counties, or if they wanted the state of Tennessee, we can do any of that customization for them to see the total incidents submitted here. And then again, down here, we have a breakdown by type. I mean, typical dashboard you're all familiar with. But this gives us quick reasoning and understanding as to what's going on where, why, and how. So I know in this data set that we've reported here, the largest proportion are my non-fatal no naloxone. 199 have been reported, representing 30% of the overall entries. Now, an analyst or somebody who's interested in digging down into that data and seeing what it looks like, let's say they're only interested in fatal overdoses where a single dose of naloxone was administered. I can go ahead and click on that, and then I can highlight it. And you'll see where they'll highlight on the screen. Now, again, looking at the whole U.S., not nearly as impactful as if I were to drill down into a specific area. And again, I just want to remind you that this is not real data. This is fake data. And I'm going to go ahead and click that again, I'm going to go ahead and click our fatal single dose of naloxone and highlight it. So I can see how they're dispersed within a given area. Just a nice quick little reference point for us to take a look at how that is being used. A couple of other search features that I have up here. I can also do a heat map. If I'm interested in looking at areas where we have the greatest concern, and if you take a quick look, you can see how they're highlighted in blue. So again, as a quick reference or a way to get into and drill down into a specific area, I'll then be able to see it like that. A couple of other search features that the system employs. We can search by type, we can search by day. So if I'm interested in seeing what was administered in the last day, I can go ahead and click that. Now, I want to show you here quickly. You can see this point, which is College Park. This is the point that we just put in just a few minutes ago. So you can see the system is updating in as quick as 20 minutes. It's almost instantaneous. So if I'm looking at multi-jurisdictions or if I'm looking at my own jurisdiction, I'll be able to see that, follow it, and look at it. Now, the question was asked earlier, are we collecting victims' names or victims' phone number? And the answer is no, we're not. When we're putting this information in here, these are the only data fields that are maintained in this system. The incident type, what type was it? This is a fatal no naloxone. The date and the timestamp. We're also going to collect the user agency. So if it's police or fire, what agency they work for, the name of the individual that's submitting the data, their email address, and their phone number. And then finally, the only thing we're collecting beyond that is the county name and the state. There's no personal identifying information being kept in this system. There's no HIPAA concerns, according to our legal attorneys. There's no worries about this data and how we're collecting it and how we're maintaining. And beyond that, the only people that can access this map in this system are people that we give access to. Let me show you a couple of other search features in the system. I'm going to just scroll out a little bit and go over a little bit. We have some good search features here. If I'm interested in looking at it by jurisdiction, by date, and by type. Let's say, for instance, here I'm interested in what's happened in Anne Arundel County in Maryland over the past year. I can just type in 365 days. I go ahead and execute it. Well, I can see there have been 32 incidents submitted within that county, again with this fictitious data, throughout that 1-year time period. I can then look and see how they're dispersed and what type they are. So again, in this instance, if I really want to zero in on our fatal doses, our fatal overdoses where a single dose of naloxone has been administered, I can click on that, I can highlight them on my map, I can zoom to them so I can get a better sense of where they are, and they're right here centered in Severna, right? So or Severn, I'm sorry. So we can see that they're all in there. There's 5 being reported in here. Of those 5, 3 are that single dose fatal no naloxone in that system. Now, Beyond that, I'm going to show it by incident type and date. So for instance, if I'm interested in looking at the map and I want to see over the past month how many fatalities where no naloxone was administered, go ahead and execute that as well. 21. I can click on this. I want to show them on the map. I'm going to zoom to it, so that'll take me out, and I can see that they're occurring across the country. I want to highlight where they are, and there they are. I can see where they're showing up on this map. So again, as an analyst, I can very quickly come in here and take a look and see what is going on where. Okay. I'm going to just take a moment and answer a couple of questions before I go in. Question is, what if an overdose is brought to an emergency room directly, not via EMS or police? Can hospital personnel export? Yes, we've had questions and conversations with hospitals about how to get that data. We've also had the question brought up is, you know, what if somebody just takes somebody does not call 911, there is no dispatch, and they drop them off at the hospital themselves? Okay. We would like to, at some point in time, get a hospital to agree to use the system and have it as a separate overlay. What we don't want to have happen is multiple entries in a single specific geographic location associated with that hospital reporting at the same time. But we would like to have an additional overlay or a filter where we can add that hospital data, and then we can actually see what's going on in that area. Is there a way to document the time of the incidents, especially if you're entering later? Yeah, absolutely. That's going to be a data field that we're going to enter. So again, back on that initial screen that you saw earlier, if we're here and we're entering in the time and the date, we should have another drop down available at some point in time in the future where we're going to be able to enable time and date stamp if we want to do that. Or you can call our admin in our office and we can correct that data for you. Some of the pilot programs that we're working with now, we've been able to, they sent us an Excel spreadsheet of their data dating back to January 1st. So even though we didn't start the pilot program until the 31st in some cases, we can take that previous month's worth of data and put it into the system by them just sharing a spreadsheet with us. All right, so do we follow up to determine if it's a non-fatal becomes fatal? Okay, so that's a great question as well, and this one comes up quite a bit. This is a real-time surveillance tool. So the most important data piece that we're picking up on this map and as we're looking at this is the fact that an incident is occurring in a specific location at a specific time. So for the purposes of response, it does matter if a non-fatal eventually does turn into a fatal overdose. It does matter if they're reporting it as no naloxone, but point of fact was there was naloxone administered. That is important data, and we would like to go in, if the provider gives that information to us, we would go back into the system and correct it. We could do that. Also, if it's a non-opioid related, say we push naloxone, but it turns out it was a heart attack or something else. We can go back in time and correct that if the provider sends that information into us, and we do encourage them to send that information to us and to correct that information. We're not giving them admin rights on the system. We're maintaining that system here on a secure server, and we want to make sure that the data integrity is kept at the highest level. So if they do tell us that, we can go back into the system and correct it. But for the purposes of response, and I'll kind of talk about how we've used this system and how we've responded in just a minute, we care more about the data that's occurring at the time. We can always correct it at a later date. Level 1 access, just somebody has to repeat that. So level 1 access, these are going to be either fire, EMS, or police, anybody who's responding to a scene in real time. So whoever's going out to a scene. The level 2 is going to be any policymaker, anybody else who's got access as a policy-making decision point or something like that. Community administered naloxone, no, we're not taking that into account with this system. We're only working with our first responders, and we're only working with our fire, police, and EMS. Parameters for total incidents submitted. Those parameters, I think I discussed that a little bit. We're just using the whole system for the purposes of this test. But if we did go live in a specific county, so we went live in St. Louis, the total number of incidents could be reflective of only St. Louis or the state of Missouri, however it is that they would like to see that. I'm going to show you one other thing here. State and date is another filter that we can use. Again, if I'm interested in looking at West Virginia data for the past year, I can then click that and I can see 13 incidents were submitted. So again, with some of these filtering, we can check by jurisdiction and date, which is county level data, incident type, or then state level data, and we can get that in there. If we wanted to take a look at Maryland, I'll just do that. We can then go ahead and execute that. 439 incidents have been reported here. I do have a report feature here on the back end where I can export the data and show it. in ascending or descending order, so we can actually track those and how they're being reported throughout the state. Let me talk a little bit about how we're using the data. I'm going to pull over, and then the question is it using GIS mapping. So yeah, this map is made available. You wouldn't need any specific tools on your desktop to view this. Esri is a partner, though they have no access to our data or our secure server. They are supporting us and working with us. I should also mention this is a service that we're providing to our law enforcement, fire and EMS free of charge. Again, we see it as an opportunity for HIDTA to support the needs of public health, to support the needs of our communities, to make sure that we're addressing this critical issue that we're facing now. The statistics behind the heat map, again, within a given area, it's just the largest proportion in that area. We can probably answer that question through our tech folks a little bit more in depth offline. Email alerts, yeah, that's a good question. That's what we're going to get to right now. So let me show you what we're doing on our end. This is actually Peggy who's going to speak to you in a little bit. This is real data from one of our test counties. And what we did was they began using the system here on January 31st. And we started recording their overdoses reporting in there. And this is a county that's reporting data through their county police department. So we took the first month's worth of data, starting on the 31st and then going to the 28th. And what we wanted to do was determine the highest number of spike within that given time. And it occurred right here on February 20th, right? And we have 6 overdoses that are reported right there on February 20th. So we set an alert system into in place. So what that means is when we hit a number within a given 24-hour period at or above 6, an email alert notification not only comes to us, but then we can set it up to the provider. So if the public health office wants to be notified right away, we can do that. The police chief, the fire chief, whomever it is, we can provide that notification to them. The first time that we saw this was here on the 7th, where we hit 15 within a 24-hour period. Now, the county was aware that they were going through a spike, but they weren't aware of the exact number. They probably would have gotten to it at some point in time in the day. It's just when that 15th came through, it was that given 24-hour period, they may not have been able to get it. The county police had signed the teaming agreement with us, but up until that point, county health had not. We shared this data with county health, and they were very interested in being able to use it, and they pushed that teaming agreement through much quicker. Again, here's an instance where we can monitor this data, get it to them in real time, share it. Now, we also know, and we've had lots of conversations with public health officials around the country with, how do they respond? What do they do in an instance where a spike is being reported? Now, the first point of that is that, oftentimes public health is not aware of it because the information sharing tools that they have in place are not strong enough or sufficient. Or more importantly, they may not confirm it for 72 hours or 96 hours. One of the folks that we spoke to, fire and EMS and police don't speak to each other oftentimes. So oftentimes if fire EMS responds to a scene and it's a called non-responsive and there's a needle hanging out of their arm, they often don't report it as an overdose just because they want to maintain the protection of their providers. They fear that if the community thinks every time an overdose occurs, they'll be afraid to call 911 if police are notified. So there's a lot of different issues facing some of these big cities that we work with across the country. We also, in terms of a response, have areas where they'll send out a mobile response team or something, and they'll go out there within 72 hours. And a lot of times that's not sufficient. After 72 hours, people are dead, people have moved, people have left the city, they've gone wherever it is. So trying to get that mobile response team, which is a good practice, to operate within minutes rather than hours is a much better tool. And we see this system as being able to break down a lot of those barriers that we've had shared with us as we go through that. So in as much as when we see this spike of 15 in this particular county, they would then be able to put resources out into the community. And then more importantly, beyond that, they'll actually know where those overdoses are occurring so they can set their resources or plan how they're going to travel to those specific areas to talk to those community members. Another area, this is another county that we're monitoring as well. It started as early as the 18th. We had originally set 6 as the overdose spike here, and then we saw it at 7. One of the things that we learned in looking at this is the day prior to this, the day prior to the 2nd, was right here as the 1st, there was a spike in the supply city that supplies this county. There was a spike in the county in between this county and that supply area. So we were able to actually follow the drugs from the supply area to the next county, over to this county, and then saw a spike that evening. We shared this data in anticipation with their substance abuse folks. They were able to mobilize resources, share information with their treatment centers, and more importantly, make sure that the hospitals were made aware of it, and that all of the providers, police, fire, and EMS, all were packed with Narcan so that they could administer it when they saw it. Luckily, I don't believe we had any fatalities on that date. Again, I can't, I can only anecdotally trace it to our ability to predict that it was coming. More importantly, that's a way that we would be able to use this system. The next question is, can we receive real-time alerts of overdoses in our smartphones? Yeah, that's the goal. Right now, the system is set up to send an email alert to somebody, but we do want to send texts at some point in time. In terms of separating individuals, the question is, can we separate out individuals that are under 21 and over 21? No, the system is not designed to do that now, and I'm not sure, because we're not collecting any of that PII, that we would do that or be able to do that. That could be something that's done on the back end, or the existing system that that county or city is using to record that data. They would then be able to do that. This system is not designed to differentiate or identify who the individual victim is. The forms of naloxone administered. No, we're not defining that either. Typically, we know wherever the area is, they know what they're administering. Good question, and this is one that comes up quite a bit. The naloxone reporting form that a lot of people are using across the country, it just asks for dosage amount, right? It doesn't differentiate between 2 milligrams or 4 milligrams. So this is an issue that's going to continue to be addressed. But again, for the purposes of our system, we only care with the basic elemental information. Yes, no, Narcan, 1 dose or more than 1 dose. And that's it. So we're not collecting any of the information about what type of naloxone or what was done. It's to the best of the understanding of the provider that's on site. Just again, going through a few more of the questions here, I'd like to make sure I get them all. Would it be possible to duplicate the system for other drug prevention concerns, such as compliance checks or community drug take-back programs? I don't see why not. If an entity was concerned with doing that, they could develop a system. I think where we are as a HIDTA, high-intensity drug trafficking area, our primary concern is getting resources in the hands of our law enforcement and public health partners, and this is the best way to bring both of them together to get real data. We're not, again, it's just for first responders to enter data, not family, friends, and then the agency that administers the map is us, the Washington-Baltimore HIDTA. We maintain it, we manage it, we're funded to do so through the White House Office of National Drug Control Policy. And then the question is, knowing coverage rate, what proportion of first responders and agencies are using the app by region? No, we can share who's actively engaged in the region, and if you have access to the map, you would actually be able to see, and let me show you, I'm going to show you our test bed, or our live production bed, at a high level, but I'm going to show you one of the incidents that has been reported. So let me just take this incident right here. So this is the only data that's contained in the system. So again, it's the incident type, it's the date and the timestamp, it's the individual who put the data in there, the user agency, their email address, and their phone number, date, and time. And again, the number of 1 of 47 is just because of the large area that we're looking at right now. I don't want to drill down too far. These are just the pilot counties that we've worked with. This is how much has been submitted. 2 of the counties began on the 18th. The 3rd county began on the 31st, and clearly the numbers are quite large. So in terms of coverage rate, if you have access to this system, you could drill down and see what providers are putting what information in by what region. If I click over here, you can see this is the City of Martinsburg Fire Department that's putting this data in, so you can see by region what's going on in that area. Any concerns with hitting towers rather than, so yeah, again, the system is collecting approximate locations. If we go back here to our test data, let me drill down a little bit further. So here's a perfect example. This is our headquarter building right here in Greenbelt, Maryland, right? So as I scroll in, you're going to be able to see how this looks. Now, I can put a different overlay in here as far as our base map goes, and I can see a little bit more about what's going on here. So as I scroll into this system, this is physically our building is right here. These data points were entered using either my iPhone, the laptop that we have here in the office, or put in using the address. All of these were done in the same way, and you can see how they're dispersed. So the answer is all of these data points that are coming on are an approximate location. They're not an exact location. And yeah, different days we're going to get different results. But anybody in the public health community would love to have this level of data to know that they can pinpoint their resources here. And they know how many fatalities, they know how many doses of naloxone have been administered. They've got a law enforcement or a fire or paramedic person that they can call and contact and discuss the situation with, or email. So there's a lot of value to having this level of data here. Zip code. We don't include zip code again because we don't want to have any concerns with HIPAA. We're not taking any personal identifying information in. We have an approximate location that's geocoded to a map. This system is not intended to replace the existing system that is being used by the agency, and that data is typically held in that agency. Date and time can be changed. Yeah, if we wanted to change it, if somebody inadvertently put it in a day late, we can always change it and put it in at the correct date and time stamp. No concerns with that on the system. I do believe this is being recorded, so yeah, you'll be able to get that. So as far as the rollout, as I said, we just completed the pilot area here in the Washington-Baltimore HIDTA region. Again, Baltimore HIDTA is Maryland, DC, Virginia, and parts of West Virginia. We are now in the process of rolling this out to our other HIDTA partners. I can tell you probably the next big area is the state of New Jersey that has been talking about coming on. We've had several conversations with the state police in New Jersey. Their Attorney General's office, which is the Chief Law Enforcement Officer in New Jersey, they're unique, wants to see this system implemented in the state, and we're happy to support them and provide this as a free resource and tool to New Jersey. Raleigh, North Carolina, we've had several conversations with them. I believe they'll be the next city that we bring into the system. But we've done demos and had talks with our partners in California, Texas. We're doing one tomorrow with Dallas, Illinois, Massachusetts. We've had a lot of conversations with a lot of different people. So I anticipate in the next 6 months, this will be input in localities throughout the country. We're not taking any bystander naloxone administration at the scene. I will say we defer to the provider oftentimes, and we've had a couple of questions come up like this. So say an EMS comes in and a neighbor's administered naloxone, should that provider include the naloxone administration? The answer is yes. If the provider saw it happen, it's up to them to make the decision and the call as to what is being done. Same way, if they believe it to be an overdose, we want them to report it. It's not an official record. They'll do that back according to their existing policies and procedures. This is just a system to give us real-time surveillance as to what's going on. For clarification's sake, I think I just discussed that where it's being rolled out. We just concluded the pilot phase, and we're now ready to roll it out. We're looking to speak with fire departments, EMS, police across the country. I encourage anyone on the line who's interested in working with us to contact us via email, and we can set up either a further demo or a conversation with you directly about how to get into the program. It is a voluntary program, and like I said, we tried to make it functionally easy to be used in a variety of different areas. So please, you can contact us and we can get this in there. As far as an early warning feature, we've had that question come up quite a bit, and we've seen it work where we were able to notify a county that they had seen a spike in their supply area, and then in the counties in between. So yes, if I'm in, we know Baltimore City is the supply area in much of the Washington-Baltimore area. Philadelphia is the supply city for much of the Delaware County, Harford County area coming south on 95. Presumably, if we see a spike in those cities and the counties in between, then we can anticipate that a spike is coming down to us. Investigators know the flow of drugs, and we know how they're moving in and out of our cities. 100% participation by the first responder. We hope there's 100% participation, but really it's up to the executive to push them and to make sure that they're using this system as a common practice. You know, the best case scenario is use of this system becomes part of the training. So when you go into training and you talk about systems and reporting systems, ODMAP is a part of that training. That's where we hope to get, and that's where most of our partners right now are pushing and leaning. We've developed some very simple training protocols that you can access virtually. So if you did want to come on, and we've shared this with our partners in the Texoma HIDTA in Texas and Oklahoma, they're actually using those virtual training protocols, and they're actually using them to demo for their local fire and PD folks to get more people involved. So yeah, we hope for 100% participation. You know, we may not be getting that from all of our locations right now, but we believe in the long run we will. Is an alert triggered? Yeah. There's a lot of questions here. I think we'll get to some of these at the end. What I want to make sure is I reserve enough time for my colleague Peggy to jump in and talk a little bit more about the heroin response strategy. And what I'm going to do is turn that over to Peggy, and then make sure we come back to some of these questions as we're going.
ODMAP is part of the work plan for an effort that the Washington-Baltimore HIDTA is participating in called the Heroin Response Strategy. The Heroin Response Strategy, also known as the HRS, is a grant funded by the Office of National Drug Control Policy. And basically the project is a response to the heroin and opioid epidemic. The area of responsibility covered by the Heroin Response Strategy is right now has expanded to 20 states on the eastern portion of the United States. So if you look at the map on the slide, it's the states highlighted in pink and blue. The Washington-Baltimore HIDTA's area of responsibility includes the states that are highlighted in blue. So that's Maryland, Virginia, the District of Columbia, and then 2 counties in the eastern panhandle of West Virginia. So it's broader than just the HIDTA designated counties. It focuses on all states that are included in the heroin response strategy. The vision of the project is a partnership among public health and public safety partners in the heroin response strategy that will facilitate the sharing of information and intelligence pertaining to heroin and opioid abuse and trafficking, with an aim toward reducing both of those. Each state in the heroin response strategy is assigned a public health analyst and somebody called a drug intelligence officer, and their jobs are to support the mission of the heroin response strategy. So the mission of the heroin response strategy is to establish a public health and a public safety network that facilitates the reduction of heroin and opioid abuse and trafficking. So the responsibilities include collecting and sharing information, supporting cross-disciplinary strategic planning, and supporting operational and tactical actions that will lead to reduction in the heroin and opioid trafficking throughout the region. So the heroin response strategy had a kickoff meeting in February of 2016. And one of the many things that was discussed was the need for short-term, intermediate, and long-term responses. In the months following the kickoff meeting, the Washington-Baltimore HIDTA heroin response strategy team met with several of our law enforcement prevention and treatment initiatives to gain an understanding of the responses that were currently in place, as well as identify resources needed to be able to respond to the heroin and opioid epidemic. So through all these meetings, in year one, we were able to identify several needs. So one of the first things that we recognized was that in order to develop strategies to reduce heroin and opioid overdoses, is that we had to have tools that would enable us to figure out what the magnitude of the problem was, as well as identify indicators so that we could develop appropriate responses and strategies for combating the epidemic. So we also identified the need for sharing agreements. So while both public health and public safety have different functions and often operate separately, there's information that can be shared among the disciplines that's necessary for coming up with a combined approach to combating the heroin and opioid epidemic. So in year one, we started to identify that in addition to needing data collection platforms that were centralized, we also need, and then the sharing agreements, we also needed to identify what work products were useful to both the public health and public safety partners. So we know that that both public health and public safety have individual missions, but there are certain things that are useful to both of them. So some examples that we were able to identify through all the meetings was people needed real-time alerts for when overdose spikes were happening. It's very difficult to come up with a short-term or real-time response if you can't identify the problem in real time. We also identified that we needed more timely sharing of reports. So in kind of doing all the meetings that we had in year one, we learned that public health and public safety had different definitions of what timely meant. So we had to figure out what timely meant to the two, I guess, disciplines, and then what would be timely for coming up with the different types of responses to the epidemic. And then lastly, another example is sharing of successful best practices for reducing and preventing overdoses. So the best practices is really important, and just sharing information between disciplines. And so then I'm gonna go on to our year two, kind of where we are now. So we entered year two in January, and our Washington-Baltimore HIDTA team decided that one of the priorities for this year was to identify best practices and protocols for responding to spikes. So this is important. For example, like if you can identify a spike, then for first responders, you need to have naloxone access. In year one, we also have now partnered with CDC, and we've asked them to help us establish generic protocols that can be used as a starting point for strategic planning. So that's definitely one of our priorities for this year, and we've been working together, and we're hoping that as people sign up for ODMAP, that we'll be able to share some of the best practices from our pilot program, as well as recommendations from CDC. And then we're also working on finding ways to better share information and expand on existing sharing agreements. So, for example, if we find something that works in Maryland, in year one, we established a network so that we can share what we've learned in Maryland and send that out to the people in HIDTA in the different states to share with their local public health and public safety partnership. We also, in a meeting that Jeff and I had recently in one of the cities where we did an ODMAP demo, we got feedback saying, hey, you know, we'd really like to have a regional working group meeting. And so we're working on figuring out the logistics for that, since HIDTA has facilities where they could host such a regional meeting where people could share information. And then lastly, we're continuing to improve existing data collection platforms such as ODMAP. As I said in the beginning, there's different levels of responses that need to happen. So there's short-term response. So ODMAP is kind of geared towards helping that, but we also have other data collection platforms that kind of have the more detailed information. So kind of expanding on those and improving them so that we can measure the questions that we have and you know, make them better so that we can respond to the questions. So even though public health and public safety have distinct functions, we've found that collaboration is necessary to be able to develop responses, and that's kind of what the whole heroin response strategy is about, is getting the different disciplines to work together across regions to collect information, and share best practices.
Great. So, you know, circling back to heroin response and ODMAP, really these two programs are working hand in hand. The answer here, though, is, and has always been, information sharing. And I'll tell you, you know, we've had a lot of really great conversations across the country. As we've discussed both of these initiatives and how they work together. There are obviously concerned. I mean, you know, Tom, our director, always says, everybody is in favor of sharing information until it comes to sharing their information. And that's something that has, you know, been an issue, but we know we're getting through it. I mean, I think enough of us recognize this problem as something that needs to be addressed, and we're going to have to do it by sharing information, by working together, and by putting data out there. So that sort of concludes our formal overview, our formal conversation. There's several other questions in here. Erin, should we go through those?
Sure, you can certainly go through those questions for folks, yes. And then hopefully people will be willing to stick around. We'd like to do a brief poll at the end and get some suggestions from you guys about what you'd like to hear from next. And also, as long as I have your attention, you may also be interested, for those of you who are looking for a way to access data that you can work with, in looking into NEMSIS, the National EMS Information System, and their website is www.nemsis.org. They are a national system, and they cover EMS calls, including calls related to drug overdose.
Okay. Great, so I'll just kind of go through these in order that we see them here. The question was asked, is an alert triggered for overdoses requiring multiple naloxone doses, possible fentanyl analog? That's something we talked about, and it's certainly something we want to look into as these synthetics continue to dominate the calls and impact us. So the way the system is set up now, we could have an alert established when multiple doses are administered, yes. So the short answer is yes, we can set the system up to do that, and we've had several conversations about possibly doing that. What I think would probably be best to do that would be to work with the individual locality, county, city, whoever it is, and ask them if that's something that they want, and we can set up that customized alert system for them, how they would like to have it done. Is an alert triggered for refusal of transport? Individual with multiple visits for repeat overdoses. Again, it's only if they're treated by the provider, fire, EMS, or police. They are supposed to report everything, even if they don't take them to the hospital. If they're on site and they administer some level of service, they're supposed to respond and report it if it is in fact an overdose. Can alerts to the smartphones be separated between fatal and non-fatal ODs? Can the threshold be adjusted? Again, that's something we'd be happy to do. We would work that out with the individual partners as we work with them. I will say, as we're rolling this out across the country, a lot of this customization we might want to hold off. One of our plans is we've completed our pilot phase, and now we're going to open it up and expand, and we're going to do it, you know, in a very smart, responsible way. And then our hope is going to be that we have user group meetings to discuss how the system is being used. Customization is important for some areas, but at the same time, it does create problems and maintenance issues. So we are hoping that we can develop systems and export data in ways that are usable in broad ways across the system. Will county-funded prevention providers be able to access the data? Yes. Feel free to contact us as long as you're affiliated with a government agency. We can share that with you, yes. Can you make inferences about opioid subtype forensics or lethal characteristics? I don't think using the system to do that is a good idea. I'll ask Peggy.
So what we've done is kind of set up the options, the single dose of naloxone and multiple dose naloxone to try to be an indicator for whether fentanyl or specific analogs that require more naloxone for reversal. One of the things that I'm hoping to do as we're reviewing the pilot is to be able to compare the data that we collected to medical examiner data. So, but as many of you know, the medical examiner's data can take a couple months to become available before we can start kind of doing those comparisons and seeing how good of an indicator the buttons we have on ODMAP are.
Next question is HIDTA in Montana. Yeah, that's the Rocky Mountain HIDTA. If you do Rocky Mountain HIDTA search, you'll be able to find them. We have a great relationship with those folks. You can reach out through that group, or you can call us directly, and we'd be happy to work with you. Pushback from officers. The question is there pushback from officers using their personal cell phone to report to the OD? So the officers that are currently using the system right now have government-issued phones. The fire and paramedics are using it through their MDT, or they have a government-issued phone. We do have volunteer fire that are using personal phones, and in some instances, some of the county folks are using personal phones. We have not had pushback, though we do anticipate and know that depending upon the union agreement that the police or fire have, whatever their collective bargaining agreement is, it may prevent them from using their own cell phone. And then they can either do a data dump the way we're doing it currently right now, do it through their MDT or some other system. It'll be up to that individual police department to figure out how they're going to do that. Is it available across the U.S.? Yes. As I said, we're resourced to roll this out, and we'll do it sort of on a first come, first served basis. So we have a couple of locations that we're working with now to get them up to speed. And as I said, if you reach out to us, we'll be happy to go through the next steps to get you up and running. Again, your local HIDTA would be a good place to start as well, and express an interest in working with us, and they might be able to help us coordinate it a little bit smoother and faster, so we would encourage that. Does the use my location option provide street level location or zip code? Again, it's street level location. We're not collecting any zip codes in this system, so you saw the point on the map and where it hovers. Have all HIDTAs been approached to use this system? We have done several overviews to the HIDTA programs, and we have several that have prioritized this program. We imagine through the HRS, as Peggy discussed, that this will become a standardized tool. Right. So in the HRS, we had, there was a meeting at the end of, I think, in either November or December, where all the DIOs got together and it was presented to them. And then there was another one in December where all the PHAs across the 10 HIDTAs were presented the ODMAP materials. So we've been, and then we've had several follow-up meetings and demos within those regions. Okay, next question is when a family member administers naloxone and then they're taken to the hospital and there's a second dose administered, is the home address entered as well as the hospital? Right now, we're not entering data in at the hospital. We're entering data in at the point of service. So wherever that provider is providing the service to the victim, that's where the data is being put in. As I said, we'd like to include hospital data, but we have to be very careful with how that hospital data would be reported so that we don't have any false positives. And more importantly, we'd like to keep hospital data separate, so it would probably be entered or at least displayed on the map through a filter. The question is, are there more ambulance services or fire or police using it? Right now, it's a good split. And I think where it makes sense and where there's a willingness. So in two of our counties, what we found was law enforcement only was called to 10 to 15% of the calls. So it made sense for fire and EMS to do it, and there was a willingness for fire and EMS to provide the data and to report the data. In another county where we have police going, they're called to 100%, and they have a very strong working relationship with their fire and EMS. So it depends on that relationship. Right. And then also, like, one demo that we did, they said, like, oh, well, we would have police go to the fatal ones, and then fire and EMS would go to non-fatal, and that's kind of how they were trying to strategize that ODMAP could be used in their jurisdiction. The next question is, how can we stay updated with the areas that are using the system? We're in the process of building a broader website for the Washington-Baltimore HIDTA. So that should launch within the next 3 weeks, and we'll have an ODMAP page on there. I'll share the information with NDEWS, and maybe they can circulate it out to the group when that does go live. Can we have a generic login for all crews, or do they have to be individual logins? So the short answer is yes, you can have a generic login. Now, where that becomes problematic is in the case where we have multiple reports in a single location and we have to verify it. We just need to make sure that somebody at that agency can verify when that's put in. One of the locations that we have, they have a login assigned by shift, and they're small enough to manage it that way. We know some of the larger jurisdictions, it would be almost impossible. Chicago, for instance, there's no way we could do it in Chicago because we wouldn't be able to keep up with all of the activity that's going there. We would have to tie a data point to an individual. So yeah, it would vary whether or not we could or should do that by jurisdiction. Any interest rolling federally instead of state-by-state basis? No, there has not. Knoxville, what challenges are we forecasting for using this system for rural areas and possible remedies? So one of the issues that we've already faced is cell phone service in a given area. So if there's no data services, they can't put it in live. They'll have to take it back and put it in a different way. That's one case. We also have other areas that are patrolled by private fire and EMS. Well, we give access to private fire and EMS as a level 1 user. We would not give them access as a level 2 user. So they'd be able to input data, but they wouldn't be able to view the map. That would be reserved for the county level officials. The biggest challenge we're really facing is getting information out there and you know, in a timely, telling people, hey, we have the system available, let's go live with you. You know, that's the biggest thing is now that we've concluded our pilot phase, how best do we get folks onto the system, working the system, and that's what we're going through right now is we're learning how to do that best now. What does our city need to do to get started with this? I said that earlier. If you just contact me, you've got our, you should have our contact information, or you can go through NDEWS and get it to us. SAMHSA, or their grantees to get the system out. So yeah, we've had several very great conversations with SAMHSA. Mitra has been a great partner, if you know her, and we're very happy to work with SAMHSA. I think if there's a funding opportunity, we would certainly partner with them. We've had several federal agencies that are in favor of this. We've talked to SAMHSA, DEA, CDC, all of the law enforcement are behind this, ONDCP, PMISE, you know, the alphabet soup. Everybody's very supportive of it. I think with the new administration, as far as resources go, I think those will come in time. And this is a system that I know there's a lot of interest in supporting and growing and building to be a strong tool. What email address should we be sharing with our first responders? You can share mine. I don't know, that's probably not on the screen. J Beeson, B as in boy, EESON @wb.hida.org. If you just search my name and HIDTA, you should be able to find me. Is there a way to retroactively include the type of drug, substance, or combination of substances? So we're not collecting the type of substance in the system the way it's currently configured. That may be something that is done down the road, but right now we're not collecting that. That would be a point that's very difficult to confirm on site.
Right, and so we also are recommending that people use ODMAP as kind of like a first level alert to dig into and ask questions to kind of get to that level, and use some of the other collection tools that are in place to kind of answer those questions.
So the next question is, Chicago just mapped shootings on top of OD, or can we do that? The answer would be yeah, absolutely. I mean, the data is exportable. We can take a look at that. I think that would be something interesting to do down the road. Certainly, we're going to have to prioritize what we do with this system as we roll it out, but I think that would be something very interesting to take a look at. We've also talked about time and date stamps and rolling it out and viewing how the overdoses are moving throughout a particular area, so we can see a pathway with a time and date stamp. So we think as this system continues to roll out, there's going to be a lot of different versions that grow, and we'll be able to do different things with it. Is there a way to add a field for victim's phone number? No, we're not going to take in any personal identifying information. It is a HIPAA concern. Law enforcement can fill that out the way they typically do beyond this system. Canadian communities, yeah, we can go to Canada. The system is set up to go international. In our sandbox test bed, we've added data across the world. So if we are interested in doing it in Canadian communities, we can certainly do that. Financial cost to adopt the program, there's no cost to us. The cost would be just to add a couple minutes of training and to ask your providers, fire, EMS, or police to use the system. And then how do you monitor the system? The biggest question is, what is the response to these issues as they occur? What is the response? You know, we met recently with the National Association of City and County Health Officials, and we talked about what best practices exist across the country, and they're working on that. Everybody's working on this. That to me, in how we respond and how we get into communities, not the demand reduction, but how we respond to an active event, that's the piece that we need to really focus on, and that needs to be defined.
All right, Jeff, I'm going to jump in for a moment. I thank you for answering all of these questions, and we can certainly come back to you and get back to the questions in a minute, but I want to just throw a couple things out to folks. I want to let you all know, for instance, that we are going to post a flyer about ODMAP on ndews.org. So if you didn't catch Jeff's contact information when he was giving it out earlier, you will be able to find it there. It'll be up by tomorrow. And I also want to take a moment to ask all of you who are still with us to do our poll. It's just a couple quick questions. And so if you would just press in your answers, I would appreciate that. And then we can get back to the questions. You have a few more minutes if you like.
I have no problem running through them. Just cut us off when it's time. Our other HIDTAs like Northwest planning to implement this. Again, you know, our HIDTA partners would be a mechanism to getting this out to the first responders and the providers and the police. So yeah, they're aware of it, and they're actively discussing how to implement it in their respective areas. And if you have any questions, you should absolutely reach out to them. None of the HIDTAs that we've spoken with, all of them are very much in favor of it, and they should be able to give you some information about that. Other types of data collection platforms, real time, I would assume so.
But the main focus for us right now is, I guess step one is to identify the number of overdoses that are occurring. So we've been focusing on rolling out ODMAP at this time.
Okay. I think we discussed the contact information that'll be up there. Are there any pushback from states and departments? What are the concerns that have been raised? You know, the HIPAA question comes up quite a bit. And like I said, we've got a legal opinion about that, and the way we're collecting the data and who we're giving access to it does not violate HIPAA in any way, shape, or form. A lot of folks have discussed sort of, well, this is another system. I don't know that I want to make, you know, one of the police units that we spoke with said, I don't want to make my officers do one more thing. But then when we showed them the system, and it took 2 seconds for an officer to add the data, and they saw the reports that we send out, you know, they didn't mind and they adopted it. And that's really, you know, the pushback, it's been almost all positive. Everybody knows this is a huge issue, and this is a tool to help them combat it. And it's free, you know, that's it. What are the opinions of teams behind HRS ODMAP around the emerging practice of public health, public safety partnerships doing post-overdose well-being checks? I mean, I think that's great. I think that's part of the overall public health response.
Great, and we'd be happy to talk about that one more offline too.
Yeah, if you email us. First responders want to participate in this reporting system. Who should we direct them to? I think you have our contact information. What is the criteria to have access to the data? Again, that would be to sign a teaming agreement, to be a public health or public official representing a first responder system, substance abuse system. Those are the individuals that we would work with and sign an agreement and give them access to the map. Are there plans to expand in West Virginia? Yes, absolutely. West Virginia, we just had a great demo 2 days ago, and we've been invited over to Wheeling and a few other places. The Appalachia HIDTA supports the balance of West Virginia with us, and they've been very, very aggressive. As I said, we just did a series of 3 webinars through the Appalachia HIDTA, and you know, they cover West Virginia, Tennessee, Kentucky, along that rim there, and they've been very supportive. So yeah, West Virginia is probably a target area next. Would areas not in HIDTA County be able to sign up for the program? Yes, absolutely. You do not have to be a HIDTA County. You can join anytime. Our help desk does provide support 24/7. Again, it will depend upon volume. We're not currently resourced to handle all of the questions and all of the volume of work that could possibly come through, though. We have been in discussions for some additional resources to help us get there and continue to build this. Do you make demographic data by group, especially those groups that have little? No, we don't have any demographic data that we make available as part of this system, nothing at all. Next 3 years for HRS?
We're, for right now, we'll be having a meeting with CDC coming up about kind of future plans. So that's something that if you want to reach out to us, we'll be able to answer soon.
I mean, HRS is getting some good national and regional attention, so that's should continue to be in the news. Is this a tool for a street-level investigator to use real-time or receive relevant real-time information? We have not necessarily envisioned this as an investigative tool, though I'm sure it could be used as an investigative tool. It's really envisioned to be a public health real-time surveillance tool. There could be a component down the road where if data is being put in through a drug overdose form, that we could make a mobile form available to law enforcement just as a tool that could segment the PII into their existing case management system and then put the dot on the map at the same time. But we're not there yet. That could be a phase 2 or a phase 3. The cost, there is no cost. You don't need anything on your system, just a relatively newer operating system. Do a document describing, I think Erin said she's going to send that out to the group. We're going to go beyond the WB HIDTA. I think I talked a little bit about that. As far as how many states it's currently in, West Virginia and Maryland is part of our pilot, but we're going to continue to expand. I believe North Carolina will be up next, and then some of the other regions, Tennessee and New Jersey is going to be the next big one up. NDEWS.org, no. NDEWS is what I keep saying. Yeah, okay, great, sorry, you see that? If monitoring detects a spike, what are the options for rapid response? How many communities are doing this? So again, that's going to be up to the individual public health unit or first responder. This system isn't designed to control that. So I would encourage you, if you want to get sort of a national view on this, to contact either the federal agencies or some of the national associations that are talking about what a rapid response could be and what they're doing about it. One of the things that we are anxious to do is, as part of this system and our user community on the system, as we continue to get information, we'll populate some best practices on our website. We really do see this as a community of support, and that's the way we're going to treat it. It's not an app on your phone per se. That front end, it's just a mobile website. So you don't have to go to the Apple or Google store to buy it. You can just, we'll give you the address, and you can log in and register if we give you authorization to do so. Turn around to be signed up as an ODMAP. Again, the first thing to do is have your agency sign a teaming agreement with us, and then we will allow users to register as a level 1 user to input data. And then we'll identify those users who would be a level 2 and have access to the map. So it's as fast as a teaming agreement is signed with us. Are there any other real-time applications being developed simultaneously by other HIDTAs? I know there are a lot of different programs out there. I don't know if there's any that's being administered by a HIDTA other than this. They may be using systems, but I don't know of any that are just like this now. Are there plans to do overall data reports for the public? I think, yes, one of the questions that was asked earlier is, what research opportunities might be or evaluation opportunities might be. We're going to treat this like any program. We are going to evaluate it. We are going to do some research. We are going to generate some reports and put them out to the public as we're working through them. ODMAP, will it be possible to have ODMAP have bystanders enter the data? This is something, again, as we're looking down the road, is maybe a phase 4 or something like that. Yeah, I think this could be an option. We're not ready to have anybody but first responders enter data into it right now or for the near future. Northern Virginia counties, there is interest in Northern Virginia. We've had several demonstrations throughout that area, Arlington most recently. So we do think somebody will push that there. We did a big demonstration with Virginia Department of Health yesterday. So there's a lot of interest in that area. As I said, it's going to basically be next up is who we push with. Hospital-based medical personnel, will they have access? No, not now, not the way we envision this program. If we do develop a second layer where we are having hospitals enter data, then we can start discussing ways to give them access. Strong collaboration. So the several counties, such as San Diego, strong collaborative multi-sectoral prescription drug opioid prevention coalitions. Yeah, we agree. Thank you for sharing that with us. That's good. Do level 2 users have access to all of the data in the map or just data from their municipality? That's a great question. Yes, level 2 has access to all of the data in the map. And again, the point here is that we have cross-jurisdictional information sharing, so that if I'm a county and I'm supplied by another county and I can track those overdoses as they're occurring. And the hope would be that this promotes continued conversations across jurisdictional lines. And then I do believe this presentation is being recorded live. Looks like that's the end of the questions. Okay, entering the data on the phone versus the MDT, that's the last question. It's the same. It's a website, so you just enter the fields and type them in. If you're using the MDT and there's a keyboard, if you're using your phone, you're just entering it, you know, with your the finger, the way you're normally entering data in on a smartphone or an iPad.
Okay, thank you so much, Jeff and Peggy. I think you really started a valuable discussion with our network today. It seems like there's a lot of folks that are interested in learning more about ODMAP and maybe getting involved with what you're doing. So I hope we will see a lot of new developments in the near future. And I don't have another NDEWS Presents to announce at the moment. We're still working on planning what we're doing going forward, but please keep an eye out on the network and on our website, ndews.org, because we will be posting information there for any future webinars that we have. And once again, a full recording of this webinar and a flyer about ODMAP will be available on our website in about 1 to 2 weeks. So take a look at that information there, and we hope that we will see you again soon. Thank you so much, everyone. I appreciate all the questions.